Good day, Africa. You're welcome to another edition of AAU Talks on AAU TV. My name is Bridget Ama Denteh. Today we are talking health on AAU Talks, and we are joined in the studio by Professor Ama Graft Aikins. And today we are talking about curing our ills, the psychology of chronic disease risk and experience and care in Africa. And she is a professor of social psychology at the University of Ghana and the Dean of International Programs Office at the University of Ghana. She's also an associate PhD supervisor at the University of Amsterdam. She's a well-written person and she has peer-reviewed 106 publications. Yes. 106 publications, of which she is the sole author of 19, the lead author of 34 books, and senior author of 7 and a co-author of 45 books. I know you're interested with all these details I am telling you about her. We're going on a quick break. When we come back, we are delving more into the issues. Thank you. The Association of African Universities, in partnership with the All African Students Union and Al-Azhar University, Egypt, calls on African universities to participate in the first African Universities Olympics. Theme: Uniting African Universities through sports and recreation, mapping out strategies to achieve the Africa we want. The disciplines include basketball, football, long jump, triple jump, shot put, javelin, sprints, and a whole lot more. The teams will be formed according to the 5 geopolitical regions of Africa, namely West, East, South, North, and Central Africa. Venue: Al-Azhar University, Cairo, Egypt. Date: 14th to 18th of March 2019. Register now on blog.aau.org and also stand the chance of visiting the pyramids of Giza and other interesting sites in Cairo. For more information, visit blog.aau.org or call +233 2432 98464. You're welcome back from that short break. I'd like to introduce Professor Ama Graft Aikins. Professor, you're welcome to our studios today. Okay. I'd like you to tell us the inspiration behind the writing of your book, Curing Our Illness.
Well, so the book is based on my my inaugural lecture, my professorial inaugural lecture, which I gave at the University of Ghana in June 2016.
Okay.
And at the University of Ghana, you know, full professors give lectures, which basically details the work they've done right throughout their careers.
Okay.
It kind of sets the tone for their contributions to their discipline and maybe their contributions to society out there. Okay. So my lecture focused on the research I've been doing for the last 20 years. So I've worked largely on chronic illness experiences, focusing on Ghana, rural and urban Ghana, but also doing some work with Ghanaians in Europe. So the lecture essentially talked about my work. I'm a psychologist. Talked about psychology of risk, why we're all at risk of getting the common diseases like diabetes, hypertension, stroke, cancers, and also detail the experiences. I mean, people who live with these conditions and what they go through, and what their needs are, and also talked about caregiving. So that's basically the nub of the lecture. So the book basically is a slight sort of update of the lecture. And I thought it would be good to share it with the general public.
So that's basically the synopsis of the book you have just told us. Okay, so curing our ills. What ills then? Well,
at a very basic level, it's curing chronic illnesses.
Okay.
So I've worked largely on diabetes, hypertension, but there are also conditions like stroke, like cancers, like dementia. I mean, we have an aging population, so we have older people who have dementia, mental illnesses of all sorts. So the ills refers to the collection of conditions that people live with over a long period of time.
All right. So my next question will be your journey on academic research. What has it been like, and how have you gotten this far?
So I have an interesting history in the sense that I started off in the sciences, in biological sciences. So after A levels in physics, chemistry, biology, I did a degree in pharmacology.
Okay.
But I didn't like bench science, you know. I mean, things take too long to materialize. But in my last year as an undergraduate, we did a very interesting study looking at the effect of laughing gas on pain thresholds. We went around and gathered people. I went to university in Manchester, so we went off the street, talked to gathered student friends of ours, gave them laughing gas. I'm sure you know what laughing gas is, right? You sort of ingest it, right, and your voice goes very high, and you laugh a lot, basically. So we wanted to see whether that would have an effect on whether you could stomach pain for a long period. And I really loved that experience, and I realized that actually I like research, and I like working with people. So I thought through what I might want to do post degree, and I decided on psychology, and I haven't looked back. So I did my master's in psychology, did my PhD in psychology, but always with a focus on health. I've always been interested in health, so that's how it started really. So I began first of all with my master's looking at mental health, and then I moved into physical chronic illness.
Okay, so why is psychology important when it comes to chronic diseases?
It's important at so many levels. I mean, if you think about, for instance, first of all, what we know and what we do about what we know. It's psychology, right?
Yeah.
So, for instance, you might know that drinking too much Coke is bad for you, right? That there's a lot of sugar in Coke, that it might lead to you becoming overweight, and that might lead to other problems. So you know that. But doing something about it is a whole other matter, right? Because you love the taste of Coke, all your friends are drinking Coke, Coke ads are everywhere, right? So even the movement from thinking I should stop drinking Coke, it's not good for me, to actually stopping it has psychological implications. So when we talk about disease risk, for instance, we're interested in how people make sense of their risk status. I'll give you another example. When doctors go around and do screening, right? So doctors might go to, Joy FM might sort of do a screening exercise on a Saturday, or any of the radio stations will do that. Every time there's a screening program, we find that about 70% of Ghanaians who have high blood pressure do not know they have high blood pressure, right? So there are people going around with high blood pressure but don't know it. Why is that? And yet they know what hypertension is.
Yes.
They know that it's a big problem. So when you're trying to then get these people to understand that, okay, your blood pressure is high, you need to do something about it, you've got to tap into the psychology. Psychology is really key to these things.
Okay, so is chronic diseases, is it genetic or is lifestyle related?
It's both.
It's both.
It's both. So there are some conditions that we say are, so we say that chronic diseases have non-modifiable risks and modifiable risks. So the non-modifiable risks are things like genetics, age, gender. There are certain conditions that occur to women more than they occur to men. There are certain conditions that come when you're older. And then, of course, there are certain conditions that are genetic, like sickle cell disease, right? Then there are non-modifiable risks, and we call them modifiable because you can change your lifestyle and then reduce your risk. So that's where we talk about food, right? Fatty foods, sugary foods. We talk about exercise, lack of exercise being a big risk factor, alcohol overconsumption, and a few others, smoking, for instance. So there are some risk factors that if we take care of, we can sort of reduce our risk of getting these conditions. So it's both. Basically.
Okay, so on both sides, it cannot be treated but managed.
Well, yeah, I mean, generally speaking, yes. I mean, these days, I remember 20 years ago when I started working on diabetes, this was 1997, 1998, doctors would say you cannot cure diabetes, you can manage it. More recently, over last six years, there have been very interesting medical research activities that show that if people living with diabetes can manage their diets, can raise their activity levels, and so on, they can actually move their blood sugar levels into a sort of a normal zone. But this is very early stages of research, right? It's been done with few people, a few cohorts of research participants. But generally, most doctors will tell you that you've got to manage the condition, you live with it for the rest of your life, and that actually is the norm, yes.
Okay, so do you believe in other treatments to chronic diseases? Like the orthodox prayer, things?
Well, yeah, I
or
mean,
it's in your abstract, so.
Yes, so look, everywhere in the world, when you get a chronic disease, chronic condition, it hits you very hard. Your life changes. First of all, in Ghana, when somebody's diagnosed with diabetes or cancer, immediately people think this is a death sentence, I'm going to die, right? So of course, depression sets in, anxiety sets in, you really want to get rid of the condition. So people heal a shop, they go around and look for different kinds of treatments. Herbal treatments, prayer, faith healing, these sorts of things. But the thing that we have to be aware of is knowing whether the treatments we are using are efficacious. If you take that herb and you have diabetes, is it demonstrable that the herb will reduce your blood glucose levels?
Okay.
If not, then it's not right for you, right? I mean, we know that we have the Plant Medicine Center in Mampong, and they've been engaged in looking at different sorts of plants, herbs that can treat asthma, hypertension, diabetes, and so on. And we also know that pharmaceutical drugs, to a large extent, come from plant sources. So the idea that you can use plants to cure diseases or to manage diseases it's not a bad thing necessarily, but the thing is to see whether it's efficacious, the right dosage levels are stated, FDA or Noguchi has approved that it's safe, and so on. So that's one thing. Prayer is important in everybody's life. I mean, if you're a person of faith, prayer helps you to cope with everyday circumstances. But actually, science also shows that prayer works wonders when you're ill, right? Because of what it does to your psychology, to your physiology, and things like that. The difference, I guess, is in some of the research that I've done, is where, for instance, somebody's diabetic, and then they're told to fast for long periods. That is certainly going to cause problems for you, because fasting over long periods has bad effects on your sugar levels. It has a direct effect on your health, right? So there are certain treatments that work, some that don't work, and we have scientific evidence to show what works and what doesn't work.
Okay, so scientific evidence to show what works and what doesn't work. Despite the fact that there's type 1 diabetes, type 2, still it doesn't work for both types of diabetes.
Type 1 diabetes is even more of a complex condition than type 2. Because of course type 1 diabetes is genetic, right? And requires insulin injections. So it's a more complicated type of diabetes than type 2. So one has to be even more careful about the kinds of medicines that you take in addition to the insulin that you're injected with every day. Type 2, because it happens usually when you're older and it has lifestyle implications. That's why people experiment a lot more. But even then, as I said earlier, you have to be careful about how you're experimenting.
Okay, so what then will be some of the psychological difficulties that someone who has just been told that you have this chronic disease, what then does a person go through, some of the stresses and others?
I mean, I have very interesting I've done interviews with lots of people who have diabetes. The overriding emotion that comes when people are diagnosed, first of all, is shock. Then it's why me, why now? That question. Then it's what am I going to do, right? Because you see, there's still this perception that diabetes and other chronic illnesses are diseases of the rich, of the wealthy. So if, for instance, you feel that you're not wealthy, you're not, you don't have enough money, then diabetes then becomes a real problem, and a real economic problem as well as a health problem. So the overriding emotion is one of shock, then kind of concern, anxiety, right? Some people get depressed in the very early months, you know, what do I do? I mean, there's so many things a doctor will tell you to not to do, right? Don't eat this. You've got to exercise. You've got to do this, and then suddenly your life becomes restricted. So people struggle with that a lot. So depression, anxiety, anger sometimes. People are also in denial. Sometimes they think, oh, there's nothing wrong with me. I'm just going to go on as I should, and so on. So it's a very difficult diagnosis to be given, right? But as time goes on, people get used to it, and then they figure out ways in which they can cope with the condition.
So what if the person doesn't get used to it? Will a mental health professional be needed in that instance where the person is depressed and all of that?
It's a very good question. I mean, in other parts of the world where the health system is very strong, you have what we call a kind of a holistic care team, right? So you go into a hospital, you're not just seen to by a doctor. You have a nurse, you have a physiotherapist, you know, you have a clinical psychologist. So that's kind of like your chronic care team.
Yeah.
Which means that if you have persistent episodes of sadness or depression, then there's a clinical psychologist who can help you in the hospital setting or outside. But in Ghana, we have a capacity issue, right? We do have clinical psychologists, but they're based sort of in the main hospitals. They tend to take care of mental illnesses, if you see what I mean. Which means that they are not going to respond primarily to having maybe depression or anxiety because you are diabetic. So that's our issue. Our issue is the numbers. We don't have enough of the alternative, healthcare professionals who can give the kind of, you know, everyday care that people need.
Okay. So what then will be some of the adjustments that these people go through to make their life at least worth living? Yeah, better.
Well, I mean, I think that if you if you have good family support. So you're in a family where, okay, let's say the man of the house has been diagnosed with diabetes, but you know he's in a loving marriage, you know, loving family situation. His wife cares, his children care. That is a first important step, because then you go into your home and people care about you. So they'll make sure that they help you to do the kinds of things the doctor has asked you to do, right? So your wife might cook the right foods for you. She might even decide that everybody must eat what dad is eating, to make it better for you to change, right? And I'm actually using examples from my research, you know, where you enter certain families and the mother basically takes care of the husband's needs, changes the diet of the family because it makes it easier, you know. So good family support is really key, okay? But beyond that, of course, you know, for the person living with a condition, you know what's going on in your body. Nobody knows what's going on with you. So you still need some sort of, you know, professional sort of psychological support and so on, you know. So it's a mix of things. Having a really good family environment, good care structure does wonders. But also having some professional support will also keep you going for a long time.
Okay, thank you very much, Professor. We are going on a quick break and we'll be back shortly. When we come back, we're talking about what it is like for children with such chronic diseases.
Kampala International University, you are the torch that lights our path. In you we see a future bright, and by you the nation gaineth from services pure. The emblem that you chose is the message, unique in great and truly the such a heightened success is true, but with such a size
welcome back. This is still AAU Talks on AAU TV. Prof, I'd like you to highlight what it is like for a child with a chronic disease. Yes, how the family goes about it, how he or she goes to school, his or her social life, and all of that.
Yeah, and again, good question. We have, I remember when I was doing my PhD, even though my focus was on type 2 diabetes, which meant I was looking at adult experiences, I had the opportunity to talk to young children, teenagers, and a couple who were sort of 19 years old, 20 years old, who had type 1 diabetes. And it was interesting. I mean, so I talked to young people in Accra and then in Brong-Ahafo, because I gathered data in Greater Accra and Brong-Ahafo. And the experience, a child's experience of chronic illness is complex on many levels. For instance, if you have type 1 diabetes, which means you have to inject insulin, and you have to eat at certain times and manage, your condition very carefully, and you're at school, what it means is that your teachers must know your condition, maybe your friends must know your condition, so that they can spot when things aren't going right, okay? Or the teachers can look out and make sure you're eating at the right times and so on. But illness often causes, it affects your identity. It makes you feel different. It makes you feel less worthy than others and so on. And those sorts of feelings can be very strong in children, right? Because if you're a child, and you know this, and we've all been in primary school and secondary school, children can bully, right? Especially when they don't understand something. So stigma can be very, very acute within sort of childhood groups. So as a child, you have to manage these things, manage your identity, manage your illness, sometimes even manage your parents, because they tend to be overprotective, and so might cause problems for you by being too overprotective. So I think children go through very complex emotions as well at a time when they're not equipped to deal with those emotions. Okay, so they need even more,
attention.
More attention, more psychosocial support, more, I guess, group support. So I know that, for instance, in Kolebu, the child health department, they have tended to support children who have type 1 diabetes, and they organize groups to support children and so on. But that's Accra. If you move further afield, outside Accra, outside maybe Kumasi, we don't know what goes on and how children are supported. So these are issues that we have to talk about and do more research on.
Okay, so in your abstract again, you noted that let me read exactly. You noted that millions of Ghanaians live with diabetes and hypertension, etc. But for each Ghanaian living with a specific condition, 2 more Ghanaians are at risk. Kindly throw more light on it.
So what I mean really is, for instance, if you take diabetes, the prevalence rate of diabetes is it depends on where you're measuring, but it's between sort of 6% and sort of 9%, depending on where you are. But then if you look at the prevalence of impaired glucose tolerance, now impaired glucose tolerance is a marker for your risk of getting diabetes. It means that you're probably you don't have like a high blood glucose level, high enough to make a doctor afraid for you, but it's getting there, right? If you look at impaired glucose tolerance, you find that 3 times more people have IGT, right? So if you've got 6% prevalence, then we have about 18% IGT prevalence. So what that means is, for every person who has diabetes, there are about 3 more people who are about to get it but don't know it. So that's what I meant by that statistic.
Okay, so about to get it but then don't know it. So if you go to the hospital, won't the doctor tell you that you are getting close?
They might be able to tell you if your hospital offers spot checks on blood glucose levels, right?
Okay.
I mean, these days you go to some hospitals and they'll measure your blood pressure, so you know that you have high BP. But measuring blood glucose is quite expensive. They can get your blood, but they need the strips and they need the readers and things like that. So it can be quite expensive to actually do what we call random fasting blood sugars and so on. So it means that you may go to a hospital and know that my pressure is high, but they won't measure your blood glucose for you to know that you have IGT. So a lot of people might be going around with, impaired glucose tolerance and not move when they have it.
Oh. What then would be some of the barriers to addressing chronic disease burden in Africa?
I mean, I think the first thing we need to focus on is prevention, because our health systems aren't strong. Our health systems are developed or have been structured to address infectious diseases.
Yeah.
Okay, because when you talk about public health in Africa, in the global health community, everybody thinks about infectious disease, HIV/AIDS, tuberculosis, malaria, diarrhea, right? Those are the conditions people think about. And when you have a health system that has been structured around infectious diseases, then everything is geared towards short-term treatment and care.
Okay.
If you have malaria, the longest episode is what? A couple of weeks.
Yeah.
You take your medication, take the full course, you get better. If you have diabetes, it's a different scenario. It means that patient you're seeing today who's been diagnosed, you're likely to see them over the next 40 years if they live that long, and they'll come and see you regularly. It means you need to have a system that can absorb multiple hospital visits, right? Multiple engagements with the healthcare sector. And our systems aren't strong enough to cope with that. So the first thing I think for me has always been prevention. How do we get out there and get people to understand that it's better to prevent yourself from getting these conditions so that you don't get into the difficult situation of going to a health sector that hasn't got enough to care for you, right? So first thing is prevention. So public health interventions, education, but also thinking about ways in which we educate different kinds of groups. I mean, how do we reach young people, for instance, the millennials, of which I'm sure you're one. Right? So I mean, how do we reach your cohorts? How do we talk about health in ways that make sense to you, that helps you to make better choices about your health? So that's the big challenge. Prevention, I think, for me, is the first thing before we move into restructuring the health system, which is a lot more complex, a lot more financially intensive, and so.
Look, I was thinking prevention can work when it's lifestyle related, but when it's genetic, nothing can be done about it.
Well, I mean, to some degree, the prevalence of genetic disorders isn't as high, right, as lifestyle-related conditions or conditions that are associated with environment and things like that. The traditional ways of preventing genetic disorders really is through kind of genetic counseling. So if you're going to get married and maybe you're sickle cell, your husband is sickle cell, they might say, well, think about having a child and so on. But these have been sort of the traditional methods of preventing genetic disorders. But medical science has advanced rapidly, right, and in very, very interesting ways, particularly in the last 10 years. So I think that for me, there's great hope in terms of dealing with genetic disorders, right? But the big issue is the things we are doing to ourselves willingly, right, to get sick, right? And what do we do about that? So for me, that's where the interesting thing lies in terms of how does psychology play into that challenge and address that challenge.
Okay, so as she said earlier, your book is based on an inaugural lecture you had in 2016. What are some of the other research works you're working on at the moment?
So the core of my inaugural lecture sort of focused on my PhD research and some of the things that had evolved from there. But over the last 10 years, I've been involved in an interesting study. It's a community-based study in Gamashi. I don't know whether you know Gamashi.
I know Jamestown. Yeah.
So my institute, RIPS, Regional Institute for Population Studies, got funding to set up a demographic surveillance site in Jamestown, Ashetown, Abubushi. And then, so we're gathering survey data on health, on reproductive health, on health-seeking behavior, and so on. And then I started a small study just looking at diabetes experiences. And then over the last 10 years, it's kind of grown into a bigger study where we've interviewed people with hypertension, people with stroke. We've talked to pastors to herbalists to shrine priests, talk to children. So we're trying to understand what is going on in the community. So that's sort of the thing that I've been focused on quite a bit over the last 10 years. And especially since 2016, we've started doing interventions in the community where we run monthly health sessions. We talk about health.
Okay.
We try to address problems that people have. And we're trying to see how we can plug that community-based research into the broader national, like the national policy.
Okay.
So that's really the big thing that I'm doing.
But why Gamashi Asha
Why-
Town?
why- really?
Not
Why
text.
not? Why
Yeah.
not? But,
Gamashi is,
is what?
I don't know, but has this anyway, should I say it's very rural when it comes to Accra.
It's not rural.
It's
actually in the heart of the city. I mean, Gamashi is like right at the middle of real estate. I mean, it's next to us, next to the law courts, it's next to the Kwame Nkrumah Mausoleum, it's next to Kolebu. It's right at the heart of the city, right?
Yeah.
But the thing about Gamashi, and the other thing also, is one of the oldest communities.
Okay.
I mean, it's deeply historical.
Mm.
I mean, I find the place very fascinating. Having said that, I've done work in other communities. I've gone all the way to WA to gather data,
Oh, okay.
I've been all over
For
Ghana.
the same.
Well, yeah, I've gathered data on diabetes, hypertension in different parts of Ghana. But there's something about Gamashi that I think captures, Bridget, that captures the, what our problem is about chronic disease in Ghana, right?
Okay.
First of all, we keep thinking that chronic disease is a disease of the wealthy. Okay?
Yes.
We keep imagining that, if you're talking about chronic disease, and you're looking at people living in airports or East Legon or
they eat the
driving
junk
their
food.
fast cars and so on.
Mm-hmm.
But actually, chronic disease affects poor people even more. And poor people are also affected by infectious diseases. So they have what we call a double burden of disease, right?
Yeah.
So if you want to really get to the heart of what's going on in our country, I think you must start with these communities where people rarely think about them, right? People always think, what problems do they have, right?
Mm-hmm.
We have the problems.
Yeah.
Yeah, but for me, it's been a fascinating place to work in.
Okay.
I'm learning a lot, I remember talking to the chief priest in Gamashi.
Mm-hmm.
The chief priest basically manages all the
Yes,
shrines,
the
right, in the
shrines.
community. Yeah, and he gave me a history of the community, how he became a chief priest, the problems that people bring to him, and so on. And you really get a good sense of what's going on in the community.
Mm-hmm.
It's at once a very dynamic, cosmopolitan place,
Yes.
but it's also deeply traditional, right? So it kind of brings the best of both worlds, I feel. Have I convinced you?
Somehow.
We'll talk about this some more after the interview.
Okay, so what insights from your research would you like to share with policymakers and, doctors out there, professionals?
I mean, I think for me, the one of the things, I co-organized a conference recently, last Friday and Saturday on chronic diseases, and we had, the usual people come in, people from Ghana Health Service, Food and Drugs Authority, the NGOs, and so on. And I was saying to them on the Saturday, that I've sort of been on the fringes of policy since 1997. I started off being an unpaid intern, the young person who was at the meetings writing notes and putting reports together, not being paid for it. And this was a time when, the Ghana Health Service started talking about diabetes and hypertension. So GHS has been talking about this for 20 odd years. And every year we meet, we gather, we talk about it. Then 2012 we had a draft policy on NCDs. I understand Friday I heard that the policy is going to be reviewed. So 7 years after it was inaugurated at the College of Physicians and Surgeons, right?
Yeah.
In Ridge.
Okay.
They're going to review it. I don't know what that means. So the issue, and I argued this in my inaugural lecture, and it's in the book, that policy making in Ghana takes a long time. I mean, there's often like a 7-year, 10-year cycle from recognizing a problem to doing something about it by having a policy document. Then you probably have to wait another maybe 10 years for the policy to be implemented. If you're working in the area that I'm working in, you don't have that time. You can't wait 20 years to decide that, you know what, we're going to reduce salt levels in our bread, right? Or we're going to educate street food vendors about safety, about oil and things like this. So I think that we need to do more NCD advocacy. So people like me who've done research, we need to start going to the communities, talking to people who can actually do things very quickly. Policy is important. We still have to support policymakers, but I think we need more of a grassroots approach, right, to dealing with the issue.
10 years and people are dying with diabetes and hypertension and in the name of policy.
So I mean, if I give you the figures, for instance, you know, diabetes, I remember in the 1990s was like 2%, 2% prevalence. Now, as I said to you, it's between 6% and 10%. So each year that we do nothing, the problem gets worse. And this is a problem that has real implications: illness, disability, premature death. Family poverty, right? Chronic stress in families. So these are real issues that we need to tackle. You can't wait. So I think that for somebody like me who has been from the fringes right into the center, I see advocacy as an important thing that we have to do moving forward. We have to talk about it more, but we also have to do more. So back to my Gamashi work. I hope you'll join me there.
Yes, I will. Okay, so what will be the practical advice you give to the average man or woman who knows little about diabetes?
You know, WHO says we have to look at 5 things. We need to look at the food we eat. So less sugar, less salt, less fat. Says we have to exercise more, right? So moderate activity, 30 minutes, you know, every day, brisk walk, something like that, right? You don't need to go to a gym. You can just walk around, right? Jump, skip, you know, do something that makes your heart beat a little and makes you sweat a little, right? That's what we need to do. WHO says we shouldn't drink alcohol to excess. And in my book, I provide the amounts. So sometimes, you know, when we say don't drink too much, people say, what's too much? So they've given us, you know, some of the standards, you know, how many bottles of beer you can drink or how many tots of
within a period of time.
Exactly, right? So we have that. We shouldn't be overweight or obese, so we should watch our weight, right? And finally, we shouldn't smoke.
Thank you very much, Professor. Okay, this has been AAU Talks on AAU TV. Today we've been discussing curing our ills, the psychology of chronic disease risk, experience and care in Africa with Professor Graft Aikins. I know you've learned a lot, and her final words were, if you haven't started drinking, don't drink. And if you're in Gamashi or any other place and then you're experiencing diabetes, you know, just walk up to the hospital and get something doing about it. Thank you very much for staying tuned.